Good day, friends, and a warm welcome to this edition of 4D, which is Detailed Dialogues and Discussion in Indian Diabetes. In this series of 4D, we bring to you information, knowledge, which is shared by experts on the ground, people who know the theory, but people who also walk the talk, people who actually are able to convert this into practice. That is actually, in my opinion, one of the most difficult things to do. Reading the textbook is tough. We've all passed our exams. Sometimes we have flunked them as well. We are aware of that. But converting that English, converting that science and Latin into practice, into meaningful interventions for our patients, is not something that everyone can do. But today we have an expert, and a warm welcome to Dr. Sreekanth Hegde. Warm welcome, Dr.
Thank you, sir. Thank you.
Dr. Sreekanth is a consultant in diabetology, thyroidology, and hypertension, and he works in Mangalore in Karnataka. Dr. Sreekanth, we have heard so many times that Mangalore is the education capital of the country and the medical education capital of the country. How do you feel about that?
It's absolutely correct, sir, because for a city of this size, 500,000 population, there are 8 medical colleges in Mangalore. And you don't believe we have a place called as Deralakatte, where I work. Our medical college is there. The one road which is about a kilometer, there are 3 medical colleges back to back.
Okay.
Yeah, you must have heard about this famous show OMG Mera India on History TV.
Yes.
And our Deralakatte was featured in that episode.
That would be the highest density of doctors and medical colleges than anywhere in the world.
Absolutely, there are a lot of doctors, sir, and in that road there are 5 or 6 universities. There are 3 deemed universities and one Mangalore university is in the same road. So it's very amazing, and there are a lot of medical colleges in the city. So yeah, as you said, it's a educational capital and also banking capital. We have a lot of banks originating from this area.
Yeah, of course, though
So
this is
it's
not our topic, the history of
yeah,
Canara Bank is something that would warm any Indian's heart,
yeah,
such a long
true,
history from pre-independence, and we are grateful to those pioneers who have actually created the infrastructure for our country.
absolutely, sir.
Then, Dr. Hegde, this means that all of us, we are very good. This is our national pastime, talking about
Correct,
problems, cribbing about problems. But what it means
correct,
is that you are well qualified to talk not only about the problems, but also about the solutions for them. Not only about barriers, but about bridges as well. So, sir,
correct,
over
sir.
to you. Yeah, entire India is listening to you, and we'd like to learn about problems and also solutions. What are the solutions in your mind? How can we improve diabetes care in India?
Absolutely, sir. This is the hot topic of the day, and also it's a very we are facing day to day. I'll share a few from my perspective. Now, I've been practicing diabetology since last 10 years, and one will not believe 50% of my patients are younger generation of age less than 40-year-old. So I see 50% of my patients are in that range. So we see very alarming condition, and now we face a lot of problem, and that's the topic of today. I think we can start our presentation now.
Sure. Certainly, sir.
Okay. Okay. So today we'll be talking about the problems associated with the diabetes care in India, because there are, in our country there are a lot of hurdles. We have a lot of other things to take care of. So rapidly growing economy, people are they're urbanizing their lifestyle, so things are moving very fast. See, we are one of the most rapidly progressing economy in the world, so which comes with certain problems also. So diabetes is one of them. So now, nowadays we see diabetes cases growing like nothing before, never before. See, we have about 64 million people, diabetic individuals in our country, and within a short period of 1 or 2 decades, we'll touch 100 million patients. So that's a huge burden. So what are the problems we see in our day-to-day practice? You can go to the next slide. So, so these are the commonly seen hurdles what we see in our practice. A lack of general awareness about diabetes and its complications among the population. People are not very aware of the thing which is going to come in the future if they don't take care of their diabetes, because they don't see the whole picture, because people don't have the habit of reading the information in the correct way in the correct place, because nowadays all the WhatsApp university and all the social media, so people get carried away with the superficial informations, and they try to find a quick solution. So that generally the correct awareness is very much lacking in our population. That's one of the, I think, if we can take one reason we get to home today, this is the reason: lack of general awareness and its complication among the general population. And also diagnosis and access of treatment facilities for diabetes is sparse in the remote areas. Nowadays, the lot of tier 3 cities or the small towns also has a decent lab, but still people are not aware of the people, or the healthcare providers are not very much aware of the all the necessary tests which needs to be done to assess the patient's condition. It's not only about the glycemic levels, but also the glycemia is only the tip of the iceberg. As we all know, diabetes, when we say a layman what is diabetes, they definitely they say blood sugars are high, but it's not the end of it. There are a lot of things attached to it. That's called as the tip of the iceberg. So we don't evaluate the patient as a whole. We fail to recognize the problems in the early phase, like early kidney diseases, or the early retina diseases, or the early cardiovascular disease, or early neurological disorders. We fail to recognize, and the patient has to pay a huge price as the time goes by. And also economic disparities in the healthcare system is definitely there, because all the good healthcare systems are concentrated in the tier 1 city or tier 2 city. A small town will certainly have a less capable healthcare system. And of course, in diabetes, patients do not find a solution or any relief quickly, because there are no quick fixes in diabetes. So that's what happens. People will spend or waste time, the precious time, in the early part of their diabetes life, and later on they end up with complications. So there is definitely uh, scarcity of the healthcare system, and scarcity of the qualified healthcare professional. Diabetes healthcare is a very specific subject. It needs a very thorough training. It needs a thorough team which contains various members, such as a diabetes healthcare provider, doctor, and a nurse, and diabetes health educator. All these are they are the integral part of the system, and usually it will be lacking in the smaller towns, because there will be a single physician who will be practicing there. So the healthcare profession will be that the professional touch will not be there. And financial constraints, of course, there is a financial constraints in everywhere. People fail to buy their essential medications, and nowadays the lower substitutes of generics, which can also cause problems. So, and all these things can cause a serious problem. And also social barriers. People have a lot of taboo. People think that even now in the city like Mangalore, where I practice, people still think the insulin is one which is going to cause problems, and people still think tablets can injure kidneys. So all these things, there are a lot of barriers, because people will have their own narrative, people will have their own set of beliefs, and because probably the general lack of awareness is one which causes all these problems. We can go to next slide, please. You can see here the distribution of the direct cost involved in the diabetes care. So the major chunk is in during the hospitalization and the buying of the medications, monitoring and the laboratory tests, and the anti-diabetic medications. So these three constitutes the major healthcare expenditure here. You can see here doctor's visit, and also you can see if just see the doctor's visit and the tests. You do it correctly, you can certainly prevent the hospitalization, and that causes the maximum health expenditure. So, timely follow-ups, proper medications, and the early achievement of the target levels will certainly leads to decreased hospitalization and decreased healthcare burden. Next slide, please. So the barriers, I think this is very important here. What are the barriers related to patients and healthcare professionals? Patients barriers, I think we discussed earlier: lack of awareness and poor motivation, denying of the risk. People will not accept their problems. So they will be in the denial mode always. If I ask a patient that his glycemic levels are very high and he's in the stage of glucotoxicity, he needs a smaller course of insulin for a period of shorter period of time, patient always will be in the denial mode. But they will not agree at all. And similarly, a lot of things patient will not agree. They think if you do the any special test, something positive will come and doctor will say something terrible. So that's why they try to avoid those things. So denial is probably one of the very important thing. Stress, fear, and confusion, because they listen to a lot of others except doctors, qualified doctors. They listen to their neighbors, their friends, everybody. Nowadays, everyone is diabetes specialist. It is not bad also, but in a way, everybody has an opinion. If you say patient has certain conditions, everyone, all this mama, everybody in the family members, everyone has their own opinion. So that leads to confusion, stress, fear, leads to problems. So lack of family support, lack of trust in doctors, because all this, uh, I should say, because all these fake doctors, they create this sort of narrative that allopathy or the our evidence-based medical care leads to certain complications. That's why people try to avoid it. So that I do see such sort of scenarios every now and then. And lack of adherence to recommended guidelines is probably one of the patient-related barriers. And we have doctors also. There are certain barriers what we face or what we see. Medical training focused on acute care, because everybody is focused on the acute quick relief. So everybody wants to get their things fixed quickly. So diabetes care is one thing which requires a lot of perseverance, a lot of patience, a lot of effort, a lot of motivation. So which there is no fun here. It needs only constant work. So that's why focus is on the acute care. People want to fix their diabetes. What is the one thing which fixes sugar? You take that and things are done. It doesn't work like that, and we have that barrier. Treatment of acute disease is more rewarding to doctors, as I said earlier. Even everybody like to be in that category. Cost of having diabetes care team, lack of trained paramedics, and lack of knowledge to take certain action on right amount on at the right time, because people fail to do the tests in the index visit. People fail to initiate the insulin if it is required. People fail to recognize all this cultural or the family background on the barriers which can affect the diabetes care. People fail to give time to the patients. All these things are there, which are probably the medical barriers. If we can come out of this, certainly we can have a better diabetes care. I think we can go to the next slide, please. We have a lot of good therapies available. We are in the new generation now. We are 5G, so we have 5G medications also available. There are certain agents like SGLT2 inhibitors, such as dapagliflozin, canagliflozin, empagliflozin, can works like wonders. Can reduce the blood glucose along with the with very less chances of hypoglycemia, and also weight loss, and also added anti-hypertensive properties, and also added reno and cardioprotective properties. So also we have gliptins such as sitagliptin, saxagliptin, linagliptin. All these things can also improve the patient's quality of life, and also decrease the chance of hypoglycemia, which is probably one of the very important factors which affects the diabetes care, because patients are also worried, and also doctors are also worried, because patient may even get a bad hypoglycemia. So these sort of agents will certainly help to improve that thing. Also, we have newer generation agents such as GLP-1 analogs, and also these early initiation of these sort of medications will certainly improve the patient's quality of life. And early initiation of combination therapy is an approach to achieving glycemic goals earlier and dealing the deterioration of glycemic control with the possible better preservation of beta cell function. So, which basically it says the insulin production in our body will be continuous for a prolonged period of time without any need of any insulin injections, with the help of newer generation anti-diabetic medications. So, other probably next slide, please. So, other possible solutions are patient education and empowerment. This is very important, because now we have to educate our patients. A patient or diabetes Patient diabetes is probably diabetes is an irreversible condition. Patient will be diabetic for a longer period of time. Patient can reverse diabetes. Nowadays is very fancy word, reversal of diabetes is, but you can reverse diabetes, but diabetes pre-diabetes probably you'll reach the stage of pre-diabetes, but diabetes can anytime it can come the moment you deviate from your path. That's why the one's diabetes probably always diabetic, but he can be a good diabetic without any complication. So we buy certain electronic equipments, we buy some new gadgets. It comes with the user's manual, right? We try to find a way. We try to learn about the object. What is the phone? How it does work? What is the music system works? How does the TV work? That's the user's manual because you need to know you have a condition which lives with you for a lifelong lifetime. You better know about the condition. That's why it's very important to know about the your condition, what causes it, how to prevent it, what should be the medications, what everything you need to learn. It's an individual's right, an individual's responsibility, and also it's our physician's responsibility to teach the patients. That's why if it is possible, try to increase the awareness campaigns, try to spend time with our patient, uh, which can certainly cause a better glycemic control for a longer period of time to our patients. And telemedicine strategies is also there. Nowadays we have internet. It's a time of internet, so we can use that. We can use our social media to increase the awareness. I also do my certain. I have a YouTube channel. It's called that's my name. Dr. Sreekanth Hegde is the YouTube name, channel name. I have some 35,000 followers now. I used to blog about diabetes in our native language in Canada. So lot of people are finding it very interesting and very. I come up with new topics and newer angles. So people are trying to understand nowadays. People are very much aware now. Patients are very much aware. Like maybe it's a small example, and everyone must do such sort of activity because the internet is easily available. We must make use of this, and by using that, we can certainly create a lot of awareness, and which will help in controlling our patients' sugar levels and diabetes. Patient can have a very good quality of life. I think we can end the session here.
Thank you, Dr. Sreekanth. A wonderful discussion. And what we can see from your talk is that you actually practice, you breathe, you think diabetes care throughout the day. Another thing that comes across very strongly is the connect with the community.
Yes,
So,
sir.
of course, Dr. Sreekanth and all of us, we are community based. We all live in a community, but you
Yes,
have to be community sensitive and community oriented as well. So, community based, community sensitive, community oriented, community responsive. So, Dr.
true, sir.
Sreekanth, lots of questions coming up. You spoke about this blog. And what are the commonest challenges that you face? Like you've spoken about insulin, you've spoken about the fact that people will trust us less and they trust their neighbors more. But
True, sir.
let us structure this discussion. So the first thing would be pathophysiology of diabetes, especially
Yes, sir.
type 1 diabetes. Any
Okay.
myths that are prevalent amongst your patients about why diabetes is caused?
Yeah, see, luckily I live in the area where people are very much aware of their condition.
Hmm.
But I belong to an area. My district is. I belong to a district neighbor to Mangalore district, and there the people's awareness are very much lesser than the one where I practice because probably it's a tier one city.
Yeah.
But the people do have misconception. People think that diabetes is one thing which can be curable. That's what they think. And the people think that diabetes is some people seriously think that diabetes is reversible also, uh, reversible condition, and also people think that it happens suddenly overnight. It is not so, because diabetes, the pathophysiology of diabetes says a person will become clinical diabetic from it can go decades together yeah, it varies from person to person because type 1 diabetes can progress very fast, but more or less 90 to 95% of diabetics what we see is type 2 diabetes, and these people will progress very slowly.
Hmm.
So there's a stage called as IGT, there's a stage called as IGT under stress, then the stage of clinical diabetes, then stage of complication. There are a lot. These stages can go decades together. So there is a probably the most important thing of getting a patient becoming diabetes is the diabetogenic environment what we are living in.
Hmm.
Now nowadays things are becoming so easy. Everything is just one click away, and everything is home delivered to you. And we're doing less and less activity. If there are two things here, everybody knows it's not a rocket science. One is physical diet and the physical activity. If you ask me what among these two, which is the one very important, I say it's not probably the diet, it's the physical activity which is lacking. If we can if anybody who is a doctor or a non medical professional or non-medical professional, we can ask this question to ourselves. Now what we've been eating is probably not very different than what we've been eating during our undergraduate days or postgraduate days, but the physical activity what we used to do before is substantially low. So probably that is causing a condition called as insulin resistance, and that is probably causing the main problem of type 2 diabetes. So that's what I believe. I believe the diabetes is because of the insulin resistance, is because of the lack of physical activity. So that's
So
what I see
physical
these things.
activity is important, and we can motivate our patients also. We can explain this concept to them. Uh,
Certainly, sir.
if you're speaking with your patients in Kannada or in Tulu, can you think of any proverb or any simple sentence in Kannada or Tulu which would explain that Rome was not built in a day? Rome cannot be destroyed also in a day, so it is a slow process. Anything that comes to your mind in your local language, sir, would you like to share with all of us?
Yeah, yeah. You want me to speak in local language?
Yes.
ಡಯಾಬಿಟಿಸ್ ಹೇಳುವಂಥದ್ದು ಒಂದು ರೋಗ ಅಲ್ಲ. ರೋಗ ಅಂತ ಹೇಳಿದ್ರೆ ಅದಕ್ಕೊಂದು ಕಾರಣ ಇರ್ತದೆ. ಡಯಾಬಿಟಿಸ್ಗೆ ಒಂದು ರೋಗ ಅಂತ ಹೇಳಿ ಒಂದು ಕಾರಣ ಇರೋದಿಲ್ಲ, ಅದು ಹಲವಾರು ಕಾರಣಗಳ ಒಂದು ಗುಚ್ಚದ ಹಾಗೆ. ಡಯಾಬಿಟಿಸ್ ಬರುವುದು ನಿಧಾನವಾಗಿ ಬರ್ತದೆ. ಡಯಾಬಿಟಿಸ್ ಬಂದ ಮೇಲೆ ಅದನ್ನ ಸರಿಯಾಗಿ ಕಂಟ್ರೋಲ್ ಮಾಡ್ತಿದ್ದಲ್ಲಿ ಆ ಗ್ಲೂಕೋಸ್, ನಮ್ಮ ಹೈ ಗ್ಲೂಕೋಸ್ ಏನಿರ್ತದೆ ನಮ್ಮ ರಕ್ತದಲ್ಲಿ, ಅದು ನಮ್ಮ ದೇಹದ ಮುಖ್ಯವಾದ ಅಂಗಗಳ ಮೇಲೆ ಅದರ ದುಷ್ಪರಿಣಾಮಗಳಾಗಿ ಆ ಅಂಗಗಳಾದ ಕಣ್ಣು ಅಥವಾ ಕಿಡ್ನಿ ಅಥವಾ ನಮ್ಮ ಹಾರ್ಟ್ ಇರ್ಬೋದು, ನಮ್ಮ ಮೆದುಳು ಇರ್ಬೋದು, ರಕ್ತನಾಳಗಳಿರ್ಬೋದು, ಇದಕ್ಕೆಲ್ಲ ಅದರ ಸಮಸ್ಯೆ ಬಂದು ನಂತರ ಅದರಿಂದಾಗಿ ರೋಗಗಳು ಬರ್ತವೆ. ಸೊ ಡಯಾಬಿಟಿಸ್ ಇಸ್ ನಾಟ್ ಅ ಡಿಸೀಸ್, ಇಸ್ ಅ ಡಿಸಾರ್ಡರ್ ವಿಚ್ ಲೀಡ್ಸ್ ಟು ಮಲ್ಟಿಪಲ್ ಡಿಸೀಸಸ್. ಸೊ ಈಗ ನೀವು ಒಂದು ಟ್ರೀ ಅಂತ ತಗೊಂಡ್ರೆ, ಇಫ್ ಯು ಕ್ಯಾನ್ ಟೇಕ್ ಅ ಟ್ರೀ ಆಸ್ ಅ ಹೋಲ್, ದ ರೂಟ್ ಈಸ್ ಡಯಾಬಿಟಿಸ್, ರೆಸ್ಟ್ ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ದ ಔಟ್ಕಮ್ ಆಫ್ ಇಟ್. ರೂಟ್ಸ್ ಚೆನ್ನಾಗಿದ್ದಲ್ಲಿ ಮಾತ್ರ ಫ್ರೂಟ್ಸ್ ಮತ್ತೆ ಫ್ಲವರ್, ಅದ್ರದ್ದು ಲೀವ್ಸ್ ಎಲ್ಲವೂ ಹೆಲ್ದಿ ಆಗಿರ್ತದೆ. ರೂಟೇ ಚೆನ್ನಾಗಿಲ್ದಿದ್ದಾಗ ಎಲ್ಲ ಏನ್ ಮಾಡಿದ್ರು ವ್ಯರ್ಥ. ಸೊ ಇಫ್ ಯು ಟ್ರೀಟ್ ಯುವರ್ ಪ್ರಾಬ್ಲಮ್ ಸೂಪರ್ಫಿಷಿಯಲಿ, ಇಟ್ಸ್ ಲೈಕ್ ಪೇಂಟಿಂಗ್ ದ ಡ್ರೈ ಲೀಫ್ ವಿತ್ ಗ್ರೀನ್ ಕಲರ್. ಇಟ್ ಡಸಂಟ್ ಮೇಕ್ಸ್ ಎನಿ ಡಿಫರೆನ್ಸ್. ಬಟ್ ಇಫ್ ಯು ಟ್ರೀಟ್ ಯುವರ್ ರೂಟ್ with healthy nutrients, water, the leaves will take care of itself. You really don't have to do anything. ಸೊ ಡಯಾಬಿಟಿಸ್ ನ ಕಂಟ್ರೋಲ್ ಮಾಡೋದ್ರಿಂದ ಒಂದು ಬುಡಕ್ಕೆ ನೀವು ಕೈ ಹಾಕಿದಾಗ, ಸೊ ಬುಡನ ನೀವು ಚೆನ್ನಾಗಿ ಇಟ್ಕೊಂಡ್ರೆ ಮರ ಅಥವಾ ಗಿಡವು ಚೆನ್ನಾಗಿ ಬೆಳಿಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗ್ತದೆ. That's what I
So
believe.
that's very nice actually, and hitting the root. Of course, we have drugs, but those drugs will work only if you change your physical activity pattern and your diet pattern for the better. So
Certainly, sir.
that's a
Yeah,
pathophysiology. And then sometimes our patients don't accept diagnostics. So we
correct.
tell them that you need to get tests done. If we can't measure, we can't
Yes,
fix. And if we can't
correct.
measure accurately, then we can't fix accurately also. So
Correct.
how would we explain this in simple words?
Yes, sir. It's very important because diagnostics, I think our whole story is depending on a diagnostics. Now, because we treat values, we as a diabetes healthcare providers, we are probably, I would say, we are not even we should treat the patient in the primordial condition only. So I think something is big going to happen, we should know earlier, which only possible if you do tests in a proper way, in a proper method. Somebody who is living in a quite remote area, it will be difficult for them, but it is definitely possible to get a good quality test. So first thing would be, so I would say, what if you ask me how to, what is the challenges about this quality of the test? Now we see a lot, quite often, the patients coming up with some test results which probably not very accurate. So that's always important. Get your test done in a very certified laboratory, such as, so there are certain criteria which certify labs as is good lab, good quality lab. The NABL criteria is very important. Or if some advanced laboratories will have even College of American Pathologist accredited laboratories. Those laboratories are very accurate laboratories you can do. Or any, I think I'm telling you in a crude way. Maybe it's not the NABL and the CAP was accurate way, but the crude way is trust your doctor. That's very important. Your doctor should come first.
Yeah.
And I'm going to I'm telling you because now the people are not very dumb. People know very well, and they have connection to the same data what we have connection to. Everybody has Google, and now Chat GPT also is coming. So now I think you should trust your doctor. The person who has diabetes should trust the doctor. If you don't have to trust him lifelong, give him a chance. Just follow what he says and give him a 3 or 6 months time period, because diabetes is going to be there for many years. So give him 3 to 4 or 6 months time. See the average glucose control. See the other parameters are coming, how they are improving. And if it's working well, you should stick to the same doctor. One thing. And if you trust the doctor will know where to send this blood sample, which laboratory to do the test. So as somebody who's living in a very solo remote area, trust the doctor, and whatever the lab he says should follow always, and try to do the tests in some corner laboratory, which is standalone laboratory, which is not run by any qualified professional pathologist, or run by any physician. So I think we should avoid that. City like Mangalore, where I stay, all the big institutions, all the medical college laboratories are very accurate. And also nowadays, people living in tier one cities will have all the quality laboratories. So getting a quality test is probably not very difficult nowadays. Yes,
Two
sir.
things that come to my mind listening to you. One is that when you are speaking with the farmer or even a fisherman, you can tell them, see, when you go to get your produce weighed, whether it is wheat or rice or fish, then how important is that weighing machine? Supposing
Absolutely,
for every 10 kg, there is even a 1 kg difference. That is only 10%. You
absolutely,
will say only 10%. But if you,
absolutely.
you take 100 kg of rice or 100 kg of wheat and you get paid for only 90 kg, then what will happen? So same thing happens in glucose, and it is
Absolutely.
actually more fine. All this, that is one thing.
That's nice way, sir. It goes easily to your head. No? Nice way of explaining things. Good, sir. Yes,
And the other thing is also, if you want to cook Maggie 2 minutes, then you can use any kind of spice that you want. But if you want to cook
yeah,
good quality biryani or good quality payasam, then you have to let it simmer on the gas. Same way, give 3 or 6 months to your doctor. Diabetes is not a 2-minute Maggie kind of a thing.
exactly. Because why I said this 3 to 6 months to your doctor, because we are all we as a allopathy doctors, or Ayurvedic doctors, or naturopathic physician, or anybody for that matter, we are all fighting the same enemy, which is diabetes. So everybody has to work, because the problem is huge. And now where people fail, they give too much time without thinking. They don't know when to quit, when to change the your way. Where people don't know when to quit. People stick on to things for a long period of time. That's how they fail.
Mhm.
Now stick to your doctor. You sincerely advise, you follow the right advice what he gives. Check your glucose. We have a long-term parameter how the blood glucose behaves, such as we have fructosamine, we have HbA1c, and these are quite accurate. Gives you the average control of previous 3 months, and see how it goes. Where you've been, where you have reached, and after 6 months where you have reached. If things are improving, I think you're with the right personnel. If things are not improving, then you simply should not waste even a single minute. Also, I think you should change the doctor. So if you do that, I think things will be very easy, and people will not have anything to complain to. People will get their diabetes care quite well. Yeah.
One last question, and the request is to answer in both Kannada or Tulu and in English. So,
Yes.
many times our patients complain that diabetes management is expensive. What we
Yes.
tell them is that, of course, it may be expensive, but managing diabetes complications is 10 times more expensive.
Yes, sir.
So, the English proverbs are penny wise, pound foolish, or a stitch in time saves nine. In
Correct.
Urdu, we have a proverb, पैसे बचाओ, अशर्फियां लुटाओ. save pesas and end up spending a sharfi or gold coin. So, what would be the
100.
equivalent in Kannada or Tulu for our patients, or any other Indian language that you are comfortable in?
Probably I will put in the. I'll explain the whole thing in Kannada. I'm not getting the right. We say gade in Kannada. Proverbs we gadegalu we say. Uh, if you can remember those few slides which I showed, in which there was slide which showed the cost expenditure with each modality of the expenditure. So the highest was hospital admission. See,
Yes.
if you get nowadays everything is expensive. So is the health medical expenditure. That's there. It's very common. And how to see diabetes is certainly 100% preventable condition. I'll speak in Kannada. ಡಯಾಬಿಟಿಸ್ ಅನ್ನ ಸಂಪೂರ್ಣವಾಗಿ ನಾವು ತಡೆಗಟ್ಟಬಹುದು, ಅಥವಾ ಡಯಾಬಿಟಿಸ್ ಇಂದ ಬರುವಂತ ಸಮಸ್ಯೆಗಳನ್ನು ಕೂಡ ಕಂಪ್ಲೀಟ್ ಆಗಿ ತಡೆಗಟ್ಟಬಹುದು. ಆದರೆ ಅದನ್ನ ನೀವು ಟೈಮ್ಲಿ ನೀವು ಮಾಡದೇ ಇದ್ದಲ್ಲಿ ಏನಾಗ್ತದೆ, ಕೆಲವೊಂದು ಬೇರೆ ಸಮಸ್ಯೆಗಳಿಗೆ ಅದು ದಾರಿ ಮಾಡಿಕೊಡ್ತದೆ. ಈಗ ನಿಮ್ಗೆ ಡಯಾಬಿಟಿಸ್ ಬಹಳ ವರ್ಷದವರೆಗೆ ಡಯಾಬಿಟಿಸ್ ಇದ್ದು ಅದರಿಂದ ನಿಮ್ಗೆ ಕಿಡ್ನಿ ಸಮಸ್ಯೆ ಬಂದಲ್ಲಿ ಅದರಿಂದ ಅದಕ್ಕೆ ಆಗುವಂತ ಏನು ಖರ್ಚಿದೆಯಲ್ಲ ಅದು ನಿಮ್ಮದು, ನೀವು ಡಯಾಬಿಟಿಸ್ ಮುಂಚೆಯೇ ನೀವು ಕಂಟ್ರೋಲ್ ಮಾಡಿದ್ದಾಗ ಎಷ್ಟು ಅದ್ರದ್ದು ಎಷ್ಟೋ ಪರ್ಸೆಂಟ್ ಕಮ್ಮಿ ಇರ್ತದೆ, ಒಂದು 10% ಆಗಿರ್ಬೋದು. ಈಗ ನಿಮ್ಗೆ ಕಿಡ್ನಿ ಸಮಸ್ಯೆ ಬಂದಲ್ಲಿ ಅದಕ್ಕೆ ನೀವು ಏನು ನಿಮ್ಗೆ ಡಾಕ್ಟರ್ಗೆ ಅಥವಾ ಅದಕ್ಕೆ ಬೇಕಾಗಿರೋ ಟ್ರೀಟ್ಮೆಂಟ್ ನೀವು ಮಾಡ್ಲಿಕ್ಕೆ ಹಣವನ್ನ ಸ್ಪೆಂಡ್ ಮಾಡ್ತೀರಿ, ಅದರ 10% ಅಲ್ಲಿ ನಿಮ್ಗೆ ಎಲ್ಲ ಪೂರ್ತಿ ನಿಮ್ಮ ಡಯಾಬಿಟಿಸ್ ಕೇರ್ ಆಗ್ತಿತ್ತು. ಅದನ್ನು ಮಾಡಕ್ಕೆ ಫೇಲ್ ಆದಾಗ ಹೀಗೆ ಆಯ್ತು. ಅದೇ ತರ ಹಾರ್ಟ್ ಸಮಸ್ಯೆ ನಿಂದಿರ್ಬೋದು, ಅಥವಾ ನರಗಳ ಸಮಸ್ಯೆಯಿಂದಾಗಿ ಕಾಲುಗಳಿಗೆ ಪೆಟ್ಟಾಗಿ ಕಾಲಿನ ಗ್ಯಾಂಗ್ರೀನ್ ಆದಾಗ ಕಾಲು ಕಳ್ಕೊಳ್ಳುವಂತ ಪರಿಸ್ಥಿತಿಯೇ ಬಂದ್ಬಿಡ್ತದೆ. ಅದು ಬರದೇ ಇದ್ದಾಗ 100% ಪ್ರಿವೆಂಟಿವ್. ಎಲ್ಲಾ ರೀತಿಯ ಐ ಥಿಂಕ್ ಆಲ್ ದ ಡಯಾಬಿಟಿಸ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಆರ್ ಆಲ್ ದ ಕಾಂಪ್ಲಿಕೇಶನ್ ಬಿಕಾಸ್ ಆಫ್ ಡಯಾಬಿಟಿಸ್ ಆರ್ ಡೆಫಿನೆಟ್ಲಿ ಪ್ರಿವೆಂಟೇಬಲ್. ಇಫ್ ನಾಟ್ 100%, ಪ್ರಾಬ್ಲಿ 90% ಇಸ್ ಪ್ರಿವೆಂಟೇಬಲ್. ಸೊ ಅದನ್ನ ಮಾಡಿದಾಗ ಪ್ರಿವೆನ್ಷನ್ ಇಸ್ ಡೆಫಿನೆಟ್ಲಿ ಬೆಟರ್ ದೆನ್ ಕ್ಯೂರ್ ಅಂತ ಹೇಳಿ ನಾವು ಹೇಳಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗ್ತದೆ.
That we can use.
Yes, sir.
It's been great, Dr. Sreekanth, speaking with you. And like I said, I'm sure all of us who are listening, that feeling of being connected with the community comes across very strongly from you. I think that
Absolutely.
is what we all need. This is the 30th episode of 4D, and we are all
Yes.
working together for a happier, for a healthier, a more harmonious India. And if we are
Correct.
able to connect with the community, speak with them, then all these problems and challenges that we enumerate, we can convert them into opportunities
Yes.
for better care. It's just that we have to speak with our patients in the language that they understand, and also we
Absolutely.
all have to speak the same language. If
Yes.
in that same 1 kilometer road, Dr. Hegde says insulin is good for health, and I go and say insulin is harmful, the doctor who has written insulin doesn't know his business, then the patient will get confused. And then obviously then the patient will go to alternative care. He will say these allopathic doctors, they are not able to agree with each other. At least the Ayurvedic doctors are united in saying that allopathy is not good for health. So at least there is a consistency there. So
Yes.
that was on a lighter note, as of course. But I think we should all work together to use the same language and the right language for all our patients,
Correct.
in a language that patients can understand. Right.
Absolutely, sir. Absolutely. I 100% agree with you. Definitely.
With this, sir, we'd like to thank you once again for being with us on this show. And we look
Thanks, sir.
forward to hosting you again. We look forward to
Definitely, sir.
meeting everyone again next week on the next episode of 4D. Thank you and Jai Hind.
Certainly, sir. Thanks for your time and thanks for this wonderful opportunity. It was very good. Thank you, sir. Namaste.
Thank you, sir.